Oh, I think it just started. Okay. Hi, everyone. Welcome to our Care Partner Training with Insight. We have Dr. Emmy Scott presenting mental health and dementia in older adults. Hold on, guys. I guess. At Insight, our mission is to provide specialized care, education, and support for individuals in all stages of memory or cognitive impairment, as well as for their partners and the community. And our vision is to have a community where those living with memory or cognitive impairment are able to achieve the highest quality of life for themselves, for their care partners. Hi. We are the leader in dementia care in Northern Virginia. We do this with care, connection, and creativity. With care, we have our specialized adult day programs for people in all stages of dementia. Connection by building relationships and supporting care partners throughout their journey. And creativity by having dementia experts share their knowledge and resources because every journey is unique. And now we would like to introduce Dr. Emmy Scott. Dr. Emmy Scott is a fellowship-trained clinical neuropsychologist with specialization in neurodegenerative diseases, particularly in memory disorders and movement disorders at Inova. Prior to joining Inova, she practiced as an assistant professor of neurology at the Medical University of South Carolina in Charleston. As a neuropsychologist, Dr. Scott sees adult patients who have concerns about memory loss or cognitive changes, as well as those with established neurodegenerative or neurological conditions. In addition to her expertise in cognitive disorders, Dr. Scott has a weekly clinic for individuals with functional neurological disorders, including functional movement disorders and non-epileptic seizures, where she offers consultation and treatment services. And here is her information, and now I will pass it over to Dr. Emmy Scott. Here you go.
Thank you. So,
yeah.
See my slides.
You can share your slides now.
Okay, so they can't see it from here. All right.
Yeah.
Okay. Might need to bring you over here. Great. Technology is not on our side today.
Yeah.
But hopefully
it's glitching on my end.
Everyone can see the slides now. Can you see it as the regular view?
I can see it from my end. Let me see here. Let me see if I don't know if this is just my laptop. Okay. Just I can.
So maybe someone can comment if they see something weird besides the slides. All right, so thank you all for coming today. I'm going to be talking to you about really the interface of mental health and dementia. So traditionally, a common referral that I would get from doctors would be to differentiate between depression and dementia. But this is a much more complicated question than this. So,
yes, keep going.
Yeah. So now we know that depression can sometimes present as a risk factor for dementia. Depression can also sometimes be the very first sign of a dementia syndrome starting, and also dementia can include symptoms of depression. So we're going to discuss all the ways that these two things are related. I'll also go over briefly what a clinical evaluation would look like to help differentiate dementia or mental health conditions from, depression or mental health conditions from dementia, and some treatment strategies for all of these stages. So I'm going to go through a few case studies. So the first case study is Bill. So this is an 80-year-old gentleman who comes to me and says, my doctor says I have Alzheimer's disease, but my wife thinks I'm depressed. So this is not terribly uncommon for me to see. So I'll tell you a little bit more about Bill. So he's had 1 year of cognitive changes that have occurred concurrently with weight loss that's been unintentional, about 20 pounds, decreased appetite, loss of interest in his usual activities, as well as withdrawal from his regular activities. So on cognitive testing with his primary care provider, he performed pretty low on a standard mini mental status exam, or MMSE. So this is about 30 questions where you have to know, what today's date is. You have to memorize some words and do some other kind of mental math and things like that in your head. So he struggled with that. Because he was reporting so many symptoms of depression, we decided to have him get started on antidepressant medication and start individual therapy. So he did really well with both of these treatments. So a few months later, when I saw him, he brought me a copy of his holiday card that he wrote, and it said, "Dear friends, I have been cured of Alzheimer's. My mini mental score has improved from a 19 to a 30. So he was really excited about this, and he continued to do well for a couple of years. However, around 2 years later, he started developing more progressive problems with memory that were unrelated to mood at that time. He additionally started developing symptoms of anxiety, but not the typical symptoms of generalized anxiety disorder, which is characterized by a lot of times people describe themselves as a worrywart, being worried about just several different things, no particular theme. But instead, he was more anxious as it related to his new memory problems. So when his wife would leave the home, he would call her repeatedly, ask her where she was, when she was getting back, and things like that. So ultimately, he was diagnosed with Alzheimer's disease, but the initial diagnosis of Alzheimer's disease by his primary care provider was not wrong. Then his second diagnosis of depression was also not wrong, but in this case, the depression seems to be a prodrome or an early sign of impending Alzheimer's disease dementia. So I'm going to go over some terms first to make sure that we're all on the same page. So depression is different than just being sad and feeling down one day. So there are different types of depression that can be diagnosed, but the most common type of depression is called major depressive disorder. And this is diagnosed when someone has been sad or felt hopeless or had some kind of depressed mood symptoms, or loss of interest in their usual activities, or loss of pleasure from doing their usual activities over at least a 2-week period, plus several of these features. So sometimes there can be weight gain or weight loss, appetite increases or decreases in appetite. There's generally problems sleeping, or there will sometimes be hypersomnia, so sleeping too much. There can also be problems with energy or fatigue, feeling worthless or guilty about things that you shouldn't necessarily feel guilty for, difficulty concentrating, and sometimes recurrent thoughts of death or suicide. So depression is a fairly common diagnosis in the general population, as well as in older adults. So in older adults, the complaints of depression are often a little bit different. So there are often more physical complaints. People will complain about pain or fatigue a little bit more than mood. There will often be more problems sleeping, and particularly frequent waking up in the middle of the night and not being able to fall back asleep. Family members may notice that the person doesn't seem to be laughing or smiling as much as they used to. And then people will often describe their symptoms differently and maybe call it nerves rather than depression or anxiety. So in the general community, about 10 to 20% of older adults have depression or any type of depressive disorder. And this risk about doubles when we're looking at older adults in a residential care facility or nursing care. So depression is known to be a risk factor for dementia of any cause, particularly when the depression is chronic or when it's present in midlife. So to the right here, I've got a figure that was from a prominent journal article in the Lancet in 2020, where they looked at different modifiable risk factors for dementia. And so if you can see this, they've got it kind of categorized by early life, midlife, and then later life risk factors. And depression makes up about 4% of the risk for dementia. So in addition to depression, any kind of mental health condition, when it's chronic, can increase your risk of dementia. And the exact mechanisms are not known, but it may have something to do with when people are depressed, they're less likely to care for themselves, to eat healthy, to exercise, and to socialize, which we know is all of those things are good for your brain. It also may be related to neurobiological factors, including the oversecretion of cortisol that actually leads to shrinkage of the hippocampus, which is the part of our brain that helps us store new memories. And it may also be an inflammatory response. So we're not sure. Maybe it's all of these above. So I've got this graphic here just to show you how complex the relationship is between depression and cognition or dementia. There's lots of different routes that it can potentially affect your thinking. So to review what dementia is an umbrella term to describe cognitive changes that have gotten to the point where a person is no longer able to function independently. So dementia is often generally preceded by a stage called mild cognitive impairment, where there is kind of objective cognitive changes relative to the person's baseline. But at that point, the person's independent with their day-to-day activities. And we call it dementia when the memory or thinking problems have gotten to the point where you're no longer fully independent with your day-to-day activities. So there are different types of dementia, of course, Alzheimer's being the most common, but there are many different types of neurodegenerative and non-neurodegenerative forms of dementia. So depression and dementia share a lot of the same symptoms. In both, you generally will have loss of interest in your typical activities, you'll have withdrawal socially, and trouble concentrating, difficulty making decisions, changes in sleep, appetite, and energy. So when an older adult presents to me with new depression that they've never had any history of before, it is usually something that I would want to follow up over time, because late onset depression is actually relatively rare. We now know that in someone who's never had a history of depression or anxiety or a panic attack or anything before, or psychosis, who in their 70s or 80s comes for the first time having those symptoms, you start to suspect an underlying cognitive or neurological process. So I'm going to give you another case example now with Joe. So Joe has a history of a stroke several years back. He comes to me with his daughter, who has several complaints, although Joe is not concerned at all about his thinking or memory. He also doesn't have any complaints about his mood. He feels like he's doing pretty well. So his daughter, on the other hand, she is concerned about his memory, for his ability to remember to take his medications, check his blood pressure at home. She's concerned about his decision making. So whenever he's presented with a task or a decision that he needs to make, he'll often just respond with, "I don't know," and doesn't make any attempt at thinking through it. However, she notices at other times he seems to be able to do things surprisingly well. So she's questioned whether some of his behaviors are intentional. She also says that he lacks awareness of any of the changes that he's had in his day-to-day functioning, physical functioning, cognitive functioning, and he's pretty resistant whenever family members or anyone, um, you points out his memory problems or makes decisions for him, and he feels like this is unfair. So she describes his personality at baseline as having a tendency to be a little bit passive aggressive. But since the stroke, this and other not particularly pleasant personality traits have seemed to amplify. So he also was previously described as funny and lovable, but now he doesn't seem to reciprocate any emotions. So she's noticed that he also lacks any kind of self-initiated behavior. So he no longer initiates chores or any activities. He'll ask his wife, who's busy, she, I believe, works from home, and she'll be in the middle of something and he'll ask her to grab him something that's closer to him than it is to her. And he doesn't seem to appreciate the fact that she's busy. He, according to his daughter, lies about following through with things that he's not following through with. For example, physical therapy, exercises, checking his blood pressure, and taking his medications regularly, things like that. And he denies doing other things that are maybe unhealthy for him, like eating a lot of sweets, despite there being clear evidence to the contrary. So he's actually been watching pornography on the computer and has forgotten to close out the browser when their grandchildren have been living with them. And this has caused a lot of problems. He completely denies this when he's asked about it. He also has done things like lie to his doctors and lie to his wife and family when there is evidence of alcohol in his breath, but he denies drinking. So I know I can't see comments if anybody has any, but I'm curious if anybody has any thoughts about what could be going on in this case.
Yes, everyone, feel free to put in the chat box what you guys have to add to this. I'll give you guys some time to put any questions in the chat box that you may have for Dr. Emmy right now.
And throughout the presentation, if you have a question, feel free to put it in the chat. Oh, yeah. It was looking kind of weird. Oh, okay. Right. So after a stroke, cognitive deficits can look very different from person to person because there's a lot of parts of the brain where you can have a stroke. So just to kind of clarify a little bit about vascular cognitive impairment as being one cause of cognitive impairment after stroke. The term vascular implies a problem with the health of your blood vessels that pump oxygen and blood flow to your brain. So in this patient's case, as a neuropsychologist who's never seen the brain imaging for this patient before, I would guess that if this is related to his past stroke, he must have had a stroke in the deeper frontal parts of the brain that are actually responsible for aspects of our personality and goal-driven behavior. So this picture here, you can see it shows the parts of the brain that are involved in what's called apathy, or the kind of loss of again, goal-directed behavior, the loss of drive. I'll often describe apathy as a syndrome where the get up and go has gotten up and left. So there are different parts of the frontal lobe that are responsible for all of these factors. And so it turns out that this patient did have a previous stroke in the frontal lobe, and that was the cause of all of these behavioral changes, which were more prominent in this case than the cognitive changes. But there are some other dementia syndromes that present the way that his does, and that includes behavioral variant frontotemporal dementia. So, all right, we're gonna go over another case next. So this is Mary, who is a very high functioning individual with a history of perfectionism, always kind of on the go. She's always been, her whole life, she's kind of taking care of other people and not really spent much time taking care of herself. So I asked her to tell me about all the problems that she has been having. So this is her response. So she says, last month, I forgot the name of the doctor that I saw. It was Dr. X. The only reason I remembered your name is because I looked it up earlier. I messed up words and spelling. For example, I forgot how to spell the word indictment. Last weekend at a family reunion, I asked someone for the Pecker Jack cheese when she meant pepper jack. It was so embarrassing. I always see the way people look at me like something is wrong with me when that happens. They say it's a weird type of aphasia. At work, I forget patients' names right after I see them. I have to set alarms to remember to live. I can't remember if I shut the garage door and have to turn back around to check it. Then I asked, have you usually closed it? Or if she ever left it open? And she said, no, I've usually always closed it. So it's actually never been a problem. So as a neuropsychologist, when I hear a patient describing their memory lapses in detail, it actually makes me a little bit less likely to think that this is an underlying dementia or neurodegenerative disease, but instead maybe somebody who's going through a lot of stress in their life. And that is what was going on in her case. So we now have, in the last few years, there's been a new diagnostic category for patients who have significant cognitive problems in their day-to-day life, but do not have an underlying structural, neurological, or neurodegenerative disorder. And this is called functional cognitive disorder. So in medicine and in neurology, we tend to create a dichotomy between syndromes that are considered structural in nature, meaning there's a problem with the physical structures of the brain or the metabolic factors in the brain, or problems that are functional in nature, meaning that the brain is not functioning properly, but there's no damage to the structure. So when people present with concerns about their cognition, and they show clear evidence in their description, for example, of their memory lapses, that their memory is quite intact, that makes us kind of raise some suspicion of a functional cognitive disorder. So in Mary's case, she had been under a lot of stress recently. She was having to pick up a second job, take care of her children. She had recently gone through a divorce. And in her case, being someone who has prided herself on her achievements and all of her accomplishments, she started worrying when she noticed the first memory lapse that she was having. But when we notice a problem with our memory and we have some experience with dementia in our lives, maybe a family member who has dementia, or maybe we work in a capacity with patients with dementia, we've got that in the back of our mind, and often that makes us a little bit afraid that the memory lapses that we have are the early signs of dementia. And so sometimes we start self-monitoring what we're saying, what we're doing, to make sure we're not making any mistakes. And then the more we are monitoring our kind of performance while we're talking or doing tasks, the more likely it is that we'll actually make a mistake cognitively, and we'll kind of create a self-fulfilling prophecy where now you've noticed or you've kind of sealed the deal. You have you're really starting to have more problems with memory, and there must be something wrong. So you start automatically thinking, "Oh my gosh, I hope this isn't dementia like my grandmother had," and you start to notice and correlate everything that you're seeing with that. A lot of times, then people can begin to avoid cognitive tasks that they previously did, and get other family members to take on the responsibility for those roles like grocery shopping. But the more that they avoid these tasks, the more they feel like they absolutely can't do it, and they may start kind of excessively taking notes. And now note taking is great as long as you've got a pretty simple strategy, but sometimes it can become out of control, and then all of this actually makes the person's thinking abilities way worse than they have to be. So this is essentially what goes on with functional cognitive disorder. So I'm going to come back to this slide in just a second. So we are going to now move into what the clinical evaluation looks like for patients who we're concerned about potentially having dementia. So if any of you have ever been to a neuropsychologist before or talked to your spouse or family member about a neuropsychological evaluation, they probably said that it was pretty long and exhausting. So we do a very comprehensive, usually about 4-hour evaluation with patients, their family members, their loved ones. We'll do an in-depth interview to find out what concerns that they have from a cognitive standpoint. Take a kind of thorough history as far as their mental health history. Find out if they have any risk factors neurologically or psychiatrically that could be contributing, and get a little bit of information about their social background, where they came from, and how they were raised, their culture. And then we'll have them do usually a couple hours of cognitive testing. So the cognitive tests that we do are not things that you have to do on a computer. They're very interactive. They're also not pass or fail. And I usually tell people that it's not as bad as you might assume that it is, and it's also usually not as boring as you might assume that it is. So I'm going to show you a few examples of some of the types of things that we have patients do in a neuropsychological evaluation. So the first picture up here is an example of a coding task where you have to kind of match numbers to symbols as quickly as you can. There's another test called the trail making test, which is very helpful, where you have patients first just connect the numbers in order as fast as they can. And then we give them a more complicated version of that test where they have to switch back and forth, connecting the numbers to the letters as fast as they can. So this is a test of multitasking, and it can be very sensitive to brain changes. Well, we may also have patients draw a complex geometric figure, and have patients name as many different words as they can think of that start with a particular letter or that fall into a particular category. We may have patients try and remember as many different words as they possibly can, and then after 30 minutes or so, ask them to tell us as many words as they can remember, just from memory. And all of this together tells us about the certain strengths and weaknesses that a patient might have cognitively, and this relates to the different types of dementia. Sorry, I keep seeing you raise your hand. I didn't know.
Did you want to answer the question?
Oh, I don't see any questions.
Oh,
please, yeah.
So someone asked, do you have any experience with whether dementia exacerbates pre-existing delusional beliefs?
I want to ask for more information there, but yeah, so pre-existing delusional beliefs. So when people get dementia and they are having delusions, the delusions are usually somehow representative of a chronic insecurity that they have or a current insecurity that they have. Not always, because they can certainly be bizarre. But if someone was always a little bit paranoid about the finances, it's not uncommon for them to, if they develop dementia, to start being more concerned about like maybe that family members or other people are stealing from their bank accounts when they can't remember what's going on with their money. Yeah, so I don't know if that answers the question. Was there?
Yep. Nope. That's it. Thank you, RJ, for your question.
Yeah. And any other questions? Feel free to just raise your hand and I'll. Since I can't see. Okay, so typically from just the cognitive tests alone, we can get a decent idea about the underlying pathology in the brain. So with Alzheimer's, we expect people to have, when I'm reading them a list of words, they'll often not benefit from hearing that same list of words several times. So we'll often see kind of a flat learning curve. Over a delay of about 30 minutes or so, even though I know that a 30-minute period is not nearly the same thing as someone's memory for things over days at a time, it's still the same part of the brain that's responsible for that type of memory. And we can often see pretty rapid forgetting of new information that was just learned 20 or 30 minutes earlier over time. So there's often a flat learning curve and accelerated forgetting of new information in Alzheimer's. And then we find that when we give them hints, was this one of the words on that list? Was that one? They do not necessarily benefit from the hints like other people might. In different types of dementia, like the frontotemporal dementias and sometimes vascular dementias, as well as dementias that come with Parkinson's disease and Lewy bodies, we'll see a problem with what's called executive functioning. And I usually describe executive functioning as being all the things that an executive would need to do to run a business. So these are things like plan, problem solve, multitask, maybe inhibit things that you might want to say to somebody but shouldn't say. These are all executive functions. So in different types of dementias, we'll see a problem with executive functioning, and that often manifests as difficulty multitasking. Right. So I'm going to talk a little bit, or I think I'm actually missing a slide here, but I'm going to talk a little bit about treatment and some things that are recommended at any stage for late life depression or mood or anxiety disorders. So in general, psychotherapy for depression and anxiety can be helpful for people of any age. The most common modalities of psychotherapy are cognitive behavioral therapy, or CBT, where this usually involves learning new skills and how to manage your depression, or learning new ways to manage stress, or kind of identifying all the things that you're actually doing, or there are ways that we're thinking that seem just automatic, and come up with ways to alternative ways of looking at things in order to improve our mood. So psychotherapy is very helpful for people with depression and anxiety, with stress, again, at any age. Although when someone has dementia, it's a little bit more difficult to have them benefit from something like cognitive behavioral therapy, because they may not be able to retain the information over time. But this does vary some from person to person. And there are other types of psychotherapy for people with dementia that can be more effective. If a person is, which I'll come back to in just a minute, if it's not possible to start psychotherapy, medications can be helpful for both depression and anxiety. These medications are generally referred to as antidepressants. Some of the more common and more benign medications that have very few side effects that someone with cognitive issues would need to worry about include sertraline, duloxetine, escitalopram, or citalopram. There are many more antidepressants besides these, but many of them have some degree of cognitive side effects. And they either can make you a little bit sleepy or somnolent, or they can affect your memory. In people with dementia, it's very important to make sure that the medications that they're taking do not have anticholinergic properties, or which is a property in some medications for mood and for other psychiatric conditions, that it takes away the chemical acetylcholine in our brain, which we need for memory, among other things. So when you have multiple medications that take away acetylcholine, that can actually worsen someone's memory. In patients with dementia that you are interacting with, so generally there's a lot of things that you can do to help improve their mental well-being. Number one, you want to reduce social isolation and loneliness. Try and increase their physical activity. And I think that I pulled up an old PowerPoint, so I apologize, sort of have all of the slides that I was looking for. But let me just pause here for questions. Are there any questions at this point?
Feel free to type in any of the questions in the Q&A box at this moment, and Dr. Emmy Scott will answer anything you may have. This is continuation?
Yeah, so I'm going back to an earlier slide where I had some thoughts that people might have when they're having some memory lapses. And it's important if any of you all are concerned about your memory, and you maybe are also a little bit stressed from helping to care for someone else with dementia, or you're working, or anything at all, it's important to remind yourself that most people do have lots of memory lapses. People between their 20s and 30s, the majority of people lose their keys frequently. The majority of people forget words at least every now and then. So a lot of this is probably normal. So instead of saying to yourself, oh my gosh, I forgot the name of someone that I have known since high school, I must be getting dementia. Remind yourself that if you are thinking that you must be getting dementia, it's automatically a little bit less likely that you're actually getting dementia, because normally that awareness is compromised. And so it's helpful to just be patient with yourself, take a deep breath, remind yourself that all these kind of lapses can be normal, and to try and move on and approach it at a different time when you're a little bit more relaxed.
Somebody asked, is there a resource list for memory exercises that are proven to work best?
So I did have a slide on this. So a lot of people that I see ask about memory exercises. There are brain training games or exercises that you can purchase online or just in a booklet. But the most amount of research that we have suggests that the best brain exercises are actually things like aerobic exercise, like cardiovascular exercise. So if you had, let's say, only 30 minutes a day to do some sort of exercise for your brain, I would say exercise your body and do some moderately vigorous aerobic activity for that 30 minutes rather than do a brain training exercise. However, it all depends on how much cognitive stimulation you're getting in your day-to-day life. So if you're still working and if you have a job that requires you to think, you are probably getting enough cognitive stimulation that it would be more helpful to do some aerobic exercise than a cognitive training exercise. However, for people who are retired and aren't responsible for as much as they were before, it can be really helpful to start volunteering. So volunteering usually involves some sort of cognitive activity. So you're having to learn some new skills, you're having to learn some new procedures, you're also having to interact with other people. And socializing is another brain exercise that is under recognized. So many people who have cognitive problems start to withdraw a little bit, but staying socially active is another one of the best things that you can do to help exercise your brain. When you're having a conversation with somebody, you're having to remember their name, you're having to remember your train of thought, you're having to pay attention to what they're saying. You're also, like I said earlier, maybe having to inhibit things you might want to say and shouldn't say. All these things are different. They're represented in different parts of your brain. So those, like socializing, is a brain exercise. So that's the long answer, but my short answer to that is I would really recommend focusing on aerobic activity and socializing and just doing things generally that you enjoy, because whatever it is that you enjoy, you're more likely to be more engaged in mentally, and you're more likely to keep it up as a habit rather than a crossword puzzle if you've never liked doing crossword puzzles before.
Okay. Thank you, Dr. Scott. Any other questions for her at this moment? Feel free to put it in the Q&A. Does dementia also exacerbate obsessive thinking or behaviors?
Yeah, so dementia can often lead to obsessive or repetitive behaviors. This varies a lot from across the different types of dementia. If I had a little bit more information, I could probably be more helpful. But there are certain types of dementia where repetitive behavior is in the criteria. So, for example, frontotemporal dementia. But other times, if someone has Alzheimer's disease and they are just generally having less activities that they're capable of doing, they might develop a repetitive behavior, kind of almost obsessive, like, tasks that they're doing, whether it's like rummaging through things or packing and unpacking their suitcase, things like that, because it's just one thing that's kind of in their control still, they're still able to do. So if it's something like that, that's not necessarily a problematic symptom. It's just, something that they're doing. I don't know if that is answering the question or not. Obsessions, I guess, in terms of thoughts, like a thought that you're kind of obsessed over, it's not typical in dementia, but it may represent a delusion, possibly.
Thank you, Dr. Scott, and thank you for asking that question. We have another one. Someone asked, are there COVID cautious social groups for elderly people? And are there COVID cautious caregiver agencies for people with early dementia?
So there definitely have been. I can't tell you off the top of my head any resources, but one good thing that came out of the COVID pandemic is that so many programs became available virtually. So I think that the staff here at Insight could probably answer that question better than I could. But I know that there are.
Yeah. So we don't have a specific COVID cautious group, but we do offer virtual support groups if you do not want to meet in person. Of course, we always advise to wear a mask if you do not feel comfortable, or if you are in public spaces. But there aren't any specific COVID cautious resources that we know of right now. But we are glad to answer any questions that you send via email, or you can contact us for more resources that we can provide to you.
Yeah, and some other things that you can do that, if you are concerned about COVID is, just invite some of your neighbors or friends. If you don't want to do virtually, at least meet outside, wear your masks, and stay appropriately. But,
Yes, absolutely. Any other questions for Dr. Scott? Do you have any questions, Regina? Okay. Okay. Looks like everybody else has, oh, here. Are there social workers who help patients' family? Yes, there are social workers. We have social workers here, and then there are other agencies that provide social workers. I don't know if you have any specific social workers that you'd want to recommend.
I know we've got, so I work at Inova in the neurology department. We do have a social worker in our department.
Yeah.
Usually a lead, but usually I would refer to.
Yes. So feel free to reach out to info@insightmcc.org, and we can provide you with a list of social workers to help with your family and your situation. Thank you. Okay. No, you're welcome. Anyone else have any questions? Okay. Well, it looks like they have all asked, and yeah, I think that concludes our. Oh, nope, sorry, someone's here. How much does ADHD and schizophrenia increase risk of dementia?
Yeah, okay, that's a good question. Schizophrenia definitely increases your risk of getting dementia. So with schizophrenia, this is something that is present. Usually it develops earlier in life. You don't typically get schizophrenia in your 50s, 60s, 70s, or later. A lot of times with schizophrenia, the very first symptom that people will notice is actually cognitive. People will be a little bit more spacey and a little bit more withdrawn, but typically people with schizophrenia do have cognitive impairments, usually kind of across the board in those cognitive domains. It's a little bit lower than somebody without schizophrenia. As they get older, a lot of times the psychotic symptoms of schizophrenia can improve later in life, but the cognitive symptoms do not. And then combined with age, and I'm not exactly sure what the mechanisms are, but cognition can worsen. Not to say that schizophrenia increases your risk of getting Alzheimer's, but one of the other non-specific types of dementia that people can get, or possibly vascular dementia. There's a significantly increased risk for schizophrenia. But ADHD, so ADHD, as far as I know, does not increase your risk of dementia. However, when you have ADHD your whole life and you then get older, where your brain starts shrinking as it does, starting in our 30s, but really more prominently in our 60s, that's going to interact with your pre-existing weak cognitive weaknesses. So people with ADHD will often complain of forgetfulness. It's not the type of forgetfulness like you see in Alzheimer's, but it's oh crap, or I just had my keys. What did I do? What was I about to say? Yeah, I can give you all sorts of examples like that, but typically that will get worse as you get older. So maybe if you are going to get dementia anyway, genetically or whatever, you could possibly notice it earlier having ADHD because the threshold is lower. There's a little bit less kind of reserve there. So you may notice the symptoms a little bit earlier, and you may notice more symptoms than you would otherwise. But I don't think that there's any correlation with actually increased risk of getting dementia.
Okay, thank you, Dr. Scott. Anyone else have any other questions? Oh, okay, yes. My family member's memory is good, but other cognitive issues, example, understanding, multitasking, difficulties, behavior changes exist. Can they be considered indicators of dementia? And does an abnormal EEG indicate along with the aforementioned?
Can you repeat that?
Yeah, no problem. Basically, they're asking, so their family member has cognitive issues, like understanding, multitasking, difficulties, behavior changes. So they're asking if these can be considered indicators of dementia, and if an abnormal EEG can indicate.
Yeah. So an abnormal EEG that's often you'll see that in dementia a lot, or cognitive disorders. Usually it's not a sign of epilepsy, which is typically what EEGs are looking for, but it'll show something like generalized slowing of brain waves, brain activity in your brain. And it's a sign that something's not right cognitively. A lot of times the diagnosis that they'll give is something like a toxic metabolic encephalopathy, which is a really non-specific term for actually like a mental status change. But that's typically what that represents. But sometimes medications, like if somebody's taking a lot of sedating medications, that can also result in an abnormal EEG that way. They can also have delirium, which is a more temporary cause of more sudden cognitive issues or confusion or lethargy that is usually something that's treatable. So urinary tract infections being one common cause of delirium. You can see the same types of brain changes on an EEG there. But otherwise, if none of those factors are irrelevant for this person, and you're seeing cognitive and behavioral changes, yeah, I would say that is concerning for something like a dementia.
Thank you for answering that. Someone also asked about their spouse displaying symptoms of dementia, and that there is currently no local area or hospital site for them to test and confirm the diagnosis. Do you have any other suggestions for where someone may get tested or diagnosed?
Yeah, so it's difficult not having anybody locally. Yeah, I don't know if I could offer any real suggestions, but you could. I think that it's important to get an accurate diagnosis and not just to assume that it's dementia or there's nothing that you can do for it. But you can try looking into the closest like academic medical center, or look for the closest cognitive or behavioral neurologist or neuropsychologist in your state, and then see if they offer virtual visits. Sometimes that is okay to do, and sometimes I feel very comfortable doing a virtual evaluation with somebody. Sometimes after doing it, I feel like I need to see them in person, but that's something that you can possibly look into.
Yes. And for this person, please reach out to info@insightmcc.org and email us, and we will we will try to do our best to look for any help for getting a testing and diagnosis for your spouse. Thank you for asking the question. And then someone also asked, does neuropsych testing include comprehensive evaluation for behavioral mental health conditions?
Yes, we tend to focus on the cognitive aspect of people's presentations, but that is part of any comprehensive neuropsychological evaluation, is to also evaluate the mood, the psychiatric and behavioral symptoms, because we know, again, that depression sometimes it can be a mental health problem and not a dementia, but then sometimes the dementia is the psychiatric and behavioral changes, and sometimes cognitive changes are less of the primary concern. So yeah, it definitely should evaluate all of that.
Thank you. And somebody asked, my husband's father has Alzheimer's. Recent tests with neurologists don't indicate Alzheimer's or frontal lobe dementia currently, but can they occur later?
Yeah, so I want more information to be able to answer that well, but sometimes the cognitive tests that we do, especially the brief screening tests like the MMSE, where you just have to remember these 3 words, are not sensitive enough to pick up on subtle cognitive changes that family members are noticing or seeing at home. Sometimes they are correct and there is nothing going on and it is a false alarm. But I certainly would hope that the neurologists or who evaluated that patient wouldn't just sign off and say they're never going to see that patient again, because I think it warrants following them over time because things may change. It's not unusual for a brain MRI to be completely unremarkable with dementia. Usually, if it's advanced dementia, there will be some clear changes in an MRI. But if it's relatively early or mild, it's not uncommon to have a normal brain MRI or imaging.
Thank you. I'm going to answer one question and then there's another question for you. So the information to contact Insight would be either through our website, insightmcc.org, or emailing info@insightmcc.org. And you can also email me as well. It's nina.davis@insightmcc.org as well, if you would want a direct answer to any of your questions. And that's nina.dav as in Victor is @insightmcc.org. And another question for you, Dr. Scott. What are the types of tests and imaging that someone with early dementia and possible mild cognitive impairment should have done? And how often should these tests be done? Example, MRI, MRA, neuropsych, etc.
So it depends. A lot of my answers, I guess, or it depends. It depends on how typical the presentation is. Sometimes if it's somebody, sometimes just from neuropsychological testing alone, I can be pretty confident that this is Alzheimer's. And if they are pretty impaired, past the point that they would be eligible for any of the newer Alzheimer's medications, and it's clearly pretty advanced, there's no need to even make them go through a brain MRI. If every other kind of test that's been done is normal. But if it's somebody who, when it's early on, it's helpful to just, the more, I hate to say the more tests that you do, the more confidence that you can have in the diagnosis, because it's not necessarily true, but at least the neurological evaluation that involves cognitive testing would be probably required. Doesn't necessarily have to include a neuropsychological evaluation, although I recommend it. But there aren't enough neuropsychologists to go around when it's a straightforward question, I guess. But a brain MRI is certainly something that I would recommend to most everyone to have it done, and that would really be the standard bit of test. But if it's more complicated, a PET scan, a different type of brain scan that uses like either a contrast agent or something that kind of highlights the plaques in the brain to tell us whether or not this is Alzheimer's versus a different type of dementia can be helpful. EEGs can sometimes be helpful, but there's no real need if the first time you do those tests and the answer is clear, like the diagnosis is clear, there's not a routine need to repeat those over time unless something changes and you have a new question or the doctor has a new question. That question might be, let's make sure this initial diagnosis that we thought was correct is actually correct. Let's see if there's not something else going on. Or sometimes there will just be different decisions that need to be made at different points in time. Like, is this person still capable of driving safely, or is it time to take away the keys? Then in that case, maybe a repeat neuropsychological evaluation would be helpful. I don't typically recommend routine neuropsychological testing every year or 2 years or so, because at some point, if patients don't have significant amnesia, you can start memorizing some of the tests, and that can potentially make it more difficult to tell if something is changing. So you don't want to do these tests too frequently, but it's just at some point it's not helpful to do it for routine purposes.
Got it. Okay, so I guess the answer to this other question, they also asked how often to have MRI, but I guess that ties in with what you were mentioning. Yeah. Okay. Thank you guys for your questions. Any other questions that you guys would like Dr. Scott to answer for you? Give it a few moments.
Okay.
stomach. Oh, it looks like there aren't any more questions right now. Oh wait, no, I lied. Do you? Oh, okay, okay. I'm not sure if you are asking. So someone asked, do you do neuropsychological testing on multiple family members? I'm not sure if they're asking us or you, but I'm going to assume they're asking you.
Yeah, so sometimes that happens. We wouldn't have everybody do it in the same day, of course, but yeah, I have seen the patient, my initial patient, and then later on, I've seen their spouse or another family member. Yeah, that's not like a huge no-no, but we do have other neuropsychologists that I work with that, if you didn't feel comfortable doing something like that, then we've got other neuropsychologists that could probably see you.
Thank you. And any other questions? Oh, yes. How do neuropsych testing accommodate people who are hard of hearing and for who English is their second language?
So, hard of hearing is something that I can answer a little more easily. So, we always tell people to wear the hearing aids, but we make sure that we are sitting in a one-on-one, distraction-free environment where there's nothing else going on, and now that we're not having to wear masks, it's much easier to recognize whenever anybody is having trouble hearing us. But if they don't do well on something that requires them to repeat what I've said or what the neuropsychologist has said, then we'll try and add some extra accommodations. And usually there's a point where it's clear that they are hearing us. Mm-hmm. And so we kind of make sure that that's a first kind of prerequisite before I would assume that somebody's scoring poorly on a memory test because they couldn't hear what I was trying to say. On the topic of language differences, so this is something that is tricky. If a person's first language is not English, and there's another language that they're more fluent in or more comfortable in, we always try and use an interpreter. But even with the interpreter, there are some caveats that we have to kind of acknowledge in our results that we get, because most of the tests that we're giving were developed based on people who were born in the United States with English is their first language, and there are cultural kind of subtleties that can make a person whose English is a second language, their scores appear lower than what they actually are. And even being bilingual is something that's so good for your brain in so many ways. It can hurt you on certain neuropsychological tests because that are timed and you're having to translate in your head one word from one language to a different language. And so it's just something that we have to kind of include as a limitation, if nothing else.
Absolutely. I totally agree. Thank you for that wonderful question. Anyone else have anything they would like to add or ask Dr. Scott at this moment? That's okay. Is there knowledge about whether it is helpful to take supplements or acetylcholine or serotonin, especially if taking antidepressants?
I could do a whole talk on this. So a lot of supplements are overrated. Some supplements are great, especially if you get lab testing done first that identifies that you're low in certain things, like supplementing with B12 if you have low B12, absolutely helpful. But there are certain over-the-counter, I guess you would call them supplements, that are marketed as being, dementia cures or memory enhancers. Prevagen is one that comes to mind, and there's absolutely for Prevagen specifically, and several other of these memory supplements that you see marketed. You see really exciting commercials that promise you a lot. there is no evidence to suggest that it's helpful. I'm using the company that makes Prevagen as an example, but they've received multiple warning letters from the FDA about false advertising, but despite that, they've still managed to just grow. There's been no clinical trials, no research studies showing that it's effective, and the mechanisms that they say that it works in the brain, it doesn't make sense. We know from like a physiological standpoint that wouldn't work. You mentioned, I think, acetylcholine supplements is another one. Acetylcholine supplements are actually not going to help your memory because acetylcholine doesn't cross the blood-brain barrier. So what the medications that are prescribed for Alzheimer's do, the way like Aricept or donepezil, the way they boost acetylcholine in the brain is by eating away the chemical that eats away acetylcholine. So we're not just adding acetylcholine to your brain because it wouldn't make it to your brain. Instead, we're giving you something that eats away the thing that eats away the acetylcholine to make what's already there work a little bit better or last longer. But I do recommend things like omega-3s. I mean, there's really hardly any downside of that for brain health, and anything that is good for your heart is good for your brain. So that answers.
And this person also asked antidepressants that reduce acetylcholine.
Yeah, so these are the medications that we call them tricyclic antidepressants, and maybe some other types too, but the ones that you also take for sleep. So I'm just having a little bit of a brain fart now, but trazodone is one, but trazodone has very little anticholinergic properties. So usually if trazodone is the only medication that is anticholinergic that somebody's taken, usually you don't notice cognitive changes, but you may. Mm-hmm. And so the ones called SSRIs or selective serotonin reuptake inhibitors, they generally do not take away acetylcholine. The biggest anticholinergic medications are Benadryl, like over-the-counter medications for allergies, not Zyrtec or Claritin, anything like that, but the ones that have the active ingredient is a long D word and it starts with dex something. That's something that is really strongly anticholinergic. Some other anticholinergic medications are sometimes used for urinary frequency and urgency, nausea, diarrhea, things like that.
Great questions, you all. Any other? Okay, yep. Thank you. I have been told that nortriptyline is a problem.
Yes, well, is a problem. You have to weigh the risks and benefits with any medication. So if nortriptyline is helping you significantly with one problem, like headache or depression or sleep, but you're noticing a little bit of grogginess, the next day, then you have to decide. You and your doctor, you have to decide what is worth it. Nortriptyline and amitriptyline do have some anticholinergic properties, and truly the effects are so variable from person to person. Sometimes people can take huge doses of amitriptyline, not have any problems. Some people can't tolerate just the smallest dose. So.
Thank you. And someone asked, can someone with early dementia with a long-time sleep disorder be effectively treated for sleep disorder? And if so, what do you recommend? So
what kind of sleep disorder? I'm thinking you probably mean insomnia, like just trouble sleeping. This is difficult. So the first thing I would recommend would be behavioral changes. So making sure that as much as you can, they're exposed to a bunch of light during the day. They're active physically and cognitively during the day. And we try and avoid naps in the late afternoons, at least. I know sometimes you can't avoid naps. Sometimes you shouldn't avoid naps. But in the late afternoons, it particularly becomes an issue, or falling asleep and staying asleep that night. So if you can manage to get a routine sleep pattern, sleep schedule, try that first. Otherwise, I don't want to recommend a specific sleep medication because I don't know the exact all the details.
So they said that this person has circadian rhythm disorder, and they wake up at 6 and go to bed between 4 a.m. to 6 a.m.
Yeah, so that sounds like, yeah. So sometimes people can always have that pattern, or maybe it started from working the night shift a long time ago. I don't know. I can't answer that unless I can get more information, because there are medications that can help put you to sleep, and you can train your brain, or even actually you can try melatonin, taking melatonin at the same time every evening, about an hour or so before bed, and that can kind of train your brain to start producing the sleepy hormones at the right time of day. But that usually isn't enough in somebody who's had a chronic sleep circadian rhythm disorder for their whole life. Yeah, there are medications that can work, but they all have their potential side effects.
Thank you. Any other questions for Dr. Scott? Okay. Oh, just when I'm about to. Okay, thank you both very much. This has been excellent. You're welcome. You're very welcome. And we are happy to have Dr. Scott present all this wonderful information to each and every one of you. Okay. Okay, it looks like those are all the questions for this afternoon. Well, thank you so much. Oh, wait, no, I lied. Here it is. Oh, no. Much gratitude to all. Okay. Okay. And yeah, you can stop sharing your screen now. Okay, then. Well, thank you all so much for joining in, and we wish you a great rest of your day and have a wonderful weekend. Take care, and this will be uploaded on our website in about a week. Have a great one, guys. Bye.